Dr. Hussam, can I start?
Yes, go ahead, Dr. Ruben.
Okay, so good evening, everybody. Thanks to be with us for this 13 migraine master class tonight. And our two interesting topics for tonight will be presented by two consultant neurologists. Our first topic will be about distinguishing secondary headache disorders from migraine, strategies for diagnosis. It will be presented by Dr. Milenka Yelena Jurasic. And the second topic will be how can we better match migraine treatment to our patients' need, and will be presented by our consultant neurologist, Dr. Zakaria Ammash. So first, before starting, I would like to say thank you for Pfizer to sponsor us for this migraine master class. Thanks for the Association of Migraine Disorders, and thanks for IVPN Neuropsychiatry. So let me start by presenting for you the first consultant neurologist for tonight. Our first topic will be presented by Dr. Milenka Yelena Jurasic. Dr. Yelena is MD, is a specialist in neurology, subspecialist in neuroimmunology, and a research associate. She graduated from the Faculty of Medicine of the University of Zagreb in 1999. She enrolled in the postgraduate studies at the Faculty of Science and Mathematics of the University of Zagreb in the scientific field of biology, in the field of physiology and immunobiology. Immediately after completing her undergraduate studies in 1999, she became a master in science in 2004 with the topic measuring the elasticity of the carotid artery with three-dimensional ultrasound. Her PhD thesis was completed in 2008 on new approach non-invasive measurement of the elasticity of the carotid artery using a semi-automatic ultrasound technique. Dr. Jelena is member of the Croatian Neurological Society, the European Academy of Neurology, the Croatian Society for Neuroimmunology and Neurogenetics, the Croatian Society for Pain Prevention, the Croatian Society for Gender Differences in Neurological Diseases, the Croatian Society of Neurovascular Disorders of the Croatian Medical Association, the Croatian Society of Scientific and Technical Translators, the Croatian Medical Association Chamber and the Croatian Medical Association. Dr. Jelena, the floor is yours for the first topic for tonight.
Thank you very much for this lovely introduction, Dr. Erl Navar, and I would like to bid everyone a good evening and also wish you a warm welcome from the Danish Headache Center where I'm currently residing, and here I'm actually learning how to be a better headache doctor. So here is the topic that I prepared for tonight. I would like to thank the Association of Migraine Disorders for inviting me, as well as IVPN Neuropsychiatry. So let's start. 1 second here. Let's just see how to make it more visible to you. Okay, do you see the slides now?
Yes, perfect, doctor.
Okay. So I would like to move on and to let you know that there is a great importance to talk about headache disorders because 95% of the general population has had at least one headache in their life. And when we look at the past year prevalence, it's usually going to be 1 in 2 people that will have the headache. So it's also a thing for GP consultations, say 1 in 10 people that need to consult a medical doctor will experience a headache. It's also 1 in 3 neurological referrals and 1 in 5 of all hospital admissions. It is among the top 10 causes of disability, especially for women. And also it's associated with a great burden cost, and a great personal burden for all the headache people, meaning that they have really diminish quality of life. Okay. To know how to differentiate specific headache disorders, one should be familiar with the International Classification of Headache Disorders, namely distinguish them among the very two different topics, a topic of primary headaches and topic of secondary headaches. To see how complex a migraine can be, we can just take a look at the very differences between a migraine phenotype. It can present like a migraine without aura, with aura. It can become a chronic migraine. It can have some brainstem auras, auras that are typical, auras that are motoric, which means we can have hemiplegic migraine. And then we can have some really serious complications such as status migrainosus lasting for a long time and persistent aura without an infarction, migrainous infarction, and migraine aura triggered seizure, which we will talk about later. To start thinking of how to make a diagnosis, we usually, apart from just looking at the table presented just on the previous slide, we usually use some diagnostic tools that range from more general headache approaches to more migraine specific. But saying that, we know that migraine is still underdiagnosed, and a study here shows that about 44% of people with migraine are actually still underdiagnosed and of course undertreated. To navigate through this lecture, you will be watching in 5 different sections. So first we will talk about identifying migraine with specific symptoms and why they're important, why they will raise awareness of some kind of a secondary headache disorder. And then we will go briefly over the primary headaches, concentrating mostly on secondary headaches, raising awareness on the flag concept, and finally graduating with a clinical example. So what can we say about migraine? It's a recurrent headache disorder that is moderate to severe, characterized by throbbing and pulsating pain. Usually it's unilateral, and it's accompanied by some other associated symptoms such as nausea and or sensitivity to light and sound. The migraine features need to report to certain criteria in order for the diagnosis of migraine to be correctly established, which means that you need to have 5 of headaches that fulfill the following criteria, lasting for a period of 4 to 72 hours and fulfilling this associated symptoms that are listed right here, but you know all that. So migraine actually comes in 4 phases, and those phases are prodrome, aura, headache phase, and postdrome. So the most dramatic phase is the one with the headache, where the pain reaches really severe heights. And usually we're talking about moderate to severe headaches ranging from between, shall we say, 6, 7 to 8, 9, or 10 on the VAS scale. But it's not the place where you will confuse migraine with some other headaches. Most oftenly, you will confuse it when you look at the symptoms arising during the prodrome period that can happen 3 hours to several days prior to the migraine headache, the aura period, which lasts for 5 to 60 minutes before the headache, or the postdrome period that actually spans over 1 to 2 days after the headache itself. So migraine is all that we talked about, but migraine can be a little bit atypical, and that's where the secondary headaches come in. So migraine can be not just unilateral, but bilateral, and it can also vary during a single headache. It can be mild, not moderate or severe. It can be continuous and can last longer than 72 hours or shorter than 4 hours. It may have no accompanying features at all, and you can have some features such as aura without a headache, or have an interictal hypersensitivity. So maybe we can take a look of all the symptoms arising throughout the migraine. So migraine is more than just a headache. You're going to, as a migrainer, you're going to experience some motoric impediment, autonomic symptoms, somatosensory symptoms, special sensory symptoms, cognitive disturbances, and interictal sensitivity. Why is that important? Not to overdiagnose, because correct treatment is an imperative for any condition in medicine. So what should we do when migraine becomes a little bit different? Well, there is a possibility that the migraine patterns have changed despite the fact that migraine has been stable for a while. Maybe it's because you have become less responsive to the medication or something new has happened. What should you think of? You should be familiar with the concept of red flags. And that's how you can actually, by using a careful history, distinguish some other important conditions that are also existing. How can you distinguish migraine from other headaches? Well, I've come up with this acronym, which would say just RIP it, which means re-estimate the principal headache features, interrogate your patient for other symptoms, and perform the physical examination for sure. So when we think of that, why are we going to be mentioning primary headache disorders? Because they're much more common. They're so common that they're 98% present. But secondary headaches are so important because some of them may really be life-threatening. How does it look like in a pie chart? So all of those migrainous headaches, they are most likely a migraine in about 95% of cases. But the rest will comprise of lesions and structural causes of infective and inflammatory disorders and genetic and syndromic causes. So other conditions mimicking a migraine, we call them migraine mimics. So what are the most common migraine mimics? Here you can see that among primary headaches, there are only a few. But secondary headaches, there are many, many different types and causes. Most common are those of vascular origin, then of infectious and inflammatory origin, then of space-occupying lesions, CSF pressure, trauma, and then exposure to certain substances or some other kind of disorders. But migraine can sometimes look like something else. But in that case, we're talking about migraine being a chameleon. Since there are a variable number of symptoms showing up, we can think of epilepsy, stroke, neuropathy, reticulopathy, GI tract involvement, vestibular system involvement, cardiac involvement, something like a syncope, even multiple sclerosis or functional, i.e. psychiatric disorders. Why is it so confusing? Well, because sensory symptoms tend to push us toward either central or peripheral origin. And then there is this special transient global amnesia happening in migrainous patients, usually affecting middle-aged women and lasting for 2 to 24 hours, where there is retained identity, but memory is normal and all the investigations are normal. There you can think of other psychiatric disorders. Well, let's start from the most common ones, epileptic disorders, some other kind of vascular disorders, and psychiatric as well. The aura time is also most confusing, and most like it is occipital epilepsy. What is the main difference? The main difference is that migraine auras are usually quite simple, linear, and in black and white. Less often they're in color. In occipital epilepsy, you will have circular hallucinations, and usually they are colored. So maybe that's a bit of a tip on a distinguisher. So let's see, a primary headache has no underlying cause, but a secondary headache is the result of another condition causing traction on or inflammation of pain-sensitive structures. To see how important it is, let's see the complexity of all the systems involved and why is it so important to know? Well, it's important to know because secondary headaches have potentially dangerous causes that have good response to acute treatment, but also have specific treatments, so we should aim for that and save our patients' lives. Let's move on to primary headaches. The most common ones, most commonly confused with migraines, are actually trigeminal autonomic cephalalgias or attacks. Why? Because they're unilateral with ipsilateral cranial autonomic features. They also sometimes have a similar treatment response, and that's how they overlap with migraine. And of course, they have autonomic features as well as migraine and also associated symptoms such as nausea, and photophobia. Usually, we confuse migraine with a cluster headache, especially if we're talking about a chronic cluster patient and a chronic migraine patient. What is the greatest difference? Maybe that's a sort of a take-home message for you. Well, you should ask your patient during your headache, are you restless or do you need to remain still and silent for a while? And if their answer is, I'm really restless, then you should be thinking more of a cluster headache. And if they prefer to stay silent, then you should be thinking about chronic migraine. Then we have paroxysmal hemicrania or hemicrania continua that can mimic either episodic or chronic migraine. So what you should do is to think of pain-free intervals, and if they exist, then you should be in favor of a migraine. And also what you should do is test those headaches for indomethacin, because the response to them, if they're paroxysmal hemicrania and hemicrania continua, is practically 100%. Migraines do respond to indomethacin, but not as complete as those two do. To confuse Sanctin Suna is not that easy because they're less frequent and their duration of attacks is a lot shorter. And here we come to the next term. So it's not a secondary headache, but it's a migraine borderline. We will be mentioning 3 of those symptoms right here. This one is called cluster migraine or migraine cluster. It means that for some patients, they will have the presenting features of both migraine and clusters, but they will not meet the IHD3 criteria for either or both, which means that we think of them as being coexistent, thus coining the term cluster migraine or migraine cluster. A very important thing is to think of new daily persistent headache when a pattern of headache changes. Why? Because usually it's present in people with pre-existing history of migraine, but it's also something that resembles migraine because of throbbing pain, because of the presence of nausea, phono and photophobia, lightheadedness, and aggravation by physical activity. However, the onset is clearly remembered, and it is also persistent. The last thing we will be mentioning is hypnic headache occurring during sleep and mimicking migraine by frequency, duration, and the severity. So let's move on to secondary headaches. When can we call a headache secondary? Well, when we have diagnosed a specific disorder and documented it by scientific methods, and then the headache has developed in temporal relationship to the onset of the presumed causative disorder. What will help us is that the headache will get significantly worsened if there is worsening of the presumed causative disorder, or significantly improved if there is improvement of the causative disorder. Lastly, it should not be better accounted for by another ICHD3 diagnosis. When we look at the list of all the secondary headaches, we see that a migraine, that they can all mimic a migraine. So why is it important? Well, there are about 118 causes of potential secondary headaches, and mimicking migraine for some of them is really life-threatening. What's most important, they request and require further neurological investigation. Which are most important? Let's take a look at the Spanish study performed in a Spanish ER in Valladolid Hospital, where the results were the following. So the most common headache appearing in the ER was the one attributed to vascular disorder, which is sort of natural. When you come to think of it, most of our ER cases are strokes or TIAs. Then the second one is migraine. The third one, headache attributed to infection. The fourth one, headache attributed to non-vascular intracranial disorder, and the others were more sporadic and occasional. So let's talk a little bit more about vascular secondary headaches. They consist of stroke or other vasculopathies. They also consist of something of a concept of thunderclap headache. What does it mean? A thunderclap headache means that the peak pain intensity happens in less than a minute. Some authors say in less than 5 minutes. However, it's really fast and it's really strong. So why is it confounding migraine? Because of the pain severity and quality of the pain location and duration. And what can help you distinguish it? Well, the neurological symptoms and sign and maybe changed or altered level of alertness. Is there some connection between TIAs and migraines? Well, yes, of course. It seems to be if somebody has a TIA, especially in the posterior circulation, lasting for less than an hour. And if you're a man, and if you have had it in the previous year, and it was a migraine without an aura, you are in 30% of chance of getting a migrainous headache. There are some other, maybe less common vascular secondary disorders, such as AVMs, that usually happen in the occipital region, thus sometimes inducing migraine-like headaches with visual auras. They're usually side-locked, which means unilateral, and they're usually atypical with also atypical associated signs. And of course, you should be aware there and look for neurological signals and signs. What can we say about aneurysms? Well, aneurysms are not that uncommon these days, and the most important ones are those that are saccular. Why? Because they have a compressive effect on the surrounding tissue. And if they are symptomatic, headache will present in up to 50% of patients. And what about vascular malformations? Well, this is a really important take-home message. So usually we're talking about cavernomas or angiomas or telangiectasias that can present with either migraine with or without an aura, usually with an aura. And depending on the level, if we're talking about upper level of the brainstem system, we'll be talking about an ipsilateral headache and a little bit contralateral headache. And if we're talking about a little bit lower lesions, we'll be talking about an ipsilateral headache. Why is that important? Because it has helped scientists determine and prove that there is evidence for the involvement of brainstem in the initiation of migraine. We can also say of something about some other causes, such as cervical artery dissection. Those can be either happening in carotid arteries or vertebral arteries. Well, it seems so that headache is something that comes before neurological symptoms. It comes in closer temporal relationship before the symptoms if we're talking about posterior circulation. So there is just a time lag of only 15 hours, while if we're talking about anterior circulation or the carotid artery, there is a time lag of about 4 days. Pain is usually ipsilateral, and it's more of an aching characteristic. But if aura is present, you are expected to have a march of symptoms, first visual, then sensory, and then motoric. And that is particularly important, and it should raise awareness of a potential dissection in vertebral artery. You're in luck if some of your patients has a partial Horner system, because it will show up in 1/4 of all the people with carotid artery dissection. What's more, the dissection itself could just trigger another migraine attack. What can we say about cerebral venous thrombosis? Well, it's rather frequent and it's really migraine-like, and it is actually causing a mass effect in the head, and that's why that's why the pain starts. However, maybe you should think of it if Valsalva maneuver is really something that turns it on, or if sleep or lying down aggravates it, or if it started as a thunderclap headache, especially if the pain is worsening on straining. Then we can talk about reversible cerebral artery vasoconstriction, or RCVS, that could easily happen in postpartum period, and most commonly in women. And of course, it's migraine-like, so it's most likely throbbing with associated symptoms. It can also be triggered by Valsalva maneuver, coughing, and exertion. However, it will commonly resolve in 1 to 3 months. What about temporal arteritis? Maybe that's a little bit easier because we're expecting it to happen over 50 years of age. It's more often happening in women. It's again very migraine-like. What about SAH? Well, headache may be the only symptom in about 1/3 of patients. It's usually bilateral. It can happen anywhere in the brain and is gradually increasing. It's often associated with nausea and vomiting, but it can also, just like the dissection, be a trigger for migrainous aura. The headache with SAH, importantly, may also mimic migraine by improving with the administration of triptans. And then we have some encephalopathies that are of genetic origin, such as CADASIL, with white matter hyperintensitas, microbleeds. And what you should know that you should expect about 30% of all of your patients having a migraine, and actually as a first presenting symptoms, it will happen in about 8 to 9 of your 10 patients. Well, here there's some information of CADASIL as well, but you should concentrate on MELAS because that's the second borderline syndrome, which means that it's a mitochondrial disease. It's of genetic origin, but it's coexistent with lactic acidosis and also migraine. And it's the second migraine borderline symptom that we will talk about today. Other vascular disorders, now leaving on from CNS disorders, are like hypertension. So which hypertension is very important? Well, if your blood pressure is over 180 over 120, then you can expect a bilateral and pulsating pain that is migraine mimic-like. Or you can have an anginal headache, which means it could be either unilateral or bilateral, again, with associated symptoms in a third of the patient. It could be brought on by exercise and relieved by rest. It could be accompanied by the usual cardiac symptoms such as chest pain, pain in the left arm, radiation of the pain to the mandible, or epigastric pain in 50% of the cases. But take a look at this. Cardiac cephalalgia is the only manifestation of cardiac angina in 27% of cases. So one should think of that as well. The second most common cause in the ER after migraine, or the third actually after migraine, we have infectious diseases. So usually we see people with isolated sphenoid sinuses that have some specific location determinants, and also fever and some lab work and so on. But we could have what could be masked as a migraine is also a viral meningitis with severe throbbing bilateral headache. And of course, in that case, we're expecting a stiff neck, hopefully. It doesn't happen always, even if the meningitis is not viral, but bacterial. I have seen patients like that as well. There is a specific kind of meningitis. It's called recurrent benign meningitis or Muller-Reyes meningitis, which could be attributed to many different causes. Most oftenly, we're thinking of herpes virus, and it can occur without a fever. Thus, if you see all the symptoms of a migraine, you really might well think that it is one. And then we have a brain abscess that's really rare, but it's quite migraine-like, and sometimes it can evoke an aura as well, but it can, because of its duration, mimic status migrainosus, a very important thing to evade. Well, the last thing, or not the next thing, not the last thing, the next thing that we're going to be talking about are the neoplasms or mass lesions that occur inside the head. And usually the migraines are present in about 15% of the cases. They could present either as migraines with or without an aura. And we could be talking about colloid cysts, meningiomas, craniopharyngiomas, cerebral metastases, brainstem or brain gliomas, and pituitary tumors. So pituitary tumors sometimes end up as pituitary hemorrhage, producing a migraine-like acute headache that actually has, the patient will have a normal neurological examination. The pituitary hemorrhage can be easily overlooked and underestimated because of the thickness of the slices. So maybe you should be aware of that. And also, you should be checking for the CSF and looking for pleocytosis. Then there are some less common causes that we can mention here. It's the Handel syndrome, caused by the activation of the immune system that is also presenting as a throbbing headache. And in 80% of the cases, there are some transient neurological deficits that are usually unilateral, and most of the time presented on the left hemisphere brain, the left brain hemisphere. But what's most important here is what we can find in the lumbar puncture. So there is an elevation of the opening pressure, and then we will have a lymphocytic pleocytosis and elevated protein. What's really important is that the patients will recover completely, shall we say, in about up to 3 months' time. But if you have a patient like that with a throbbing headache, but that patient is presenting with confusion and agitation, you should actually raise concern for something quite different and really important, and that's an NMDA receptor encephalitis. Again, look for the CSF signs. Next, we're going to be talking about high and low cerebrospinal fluid pressure disorders. So we have IIH, so intracranial hypertension. So it's daily increasing, usually characterized by a daily increasing pulsating headache. And see, in most of those patients, there is usually a premorbid history of migraines. And sometimes, if that's the case, just the daily increasing headaches will make you think that what's happening is that now migraine has become a chronic version of itself. So maybe one should be aware and check with the eye doctor if there are any more signs of that, and maybe check for the CSF opening pressure. Then we have a hydrocephalus caused headache, which is usually presented as migraine-like visual aura with visual aura headaches. And in that case, usually we will have some transient visual scotomas. One of those issues is having a spontaneous intracranial hypertension, where in fact, we can also, again, have a migrainous headache, but gradually evolving. But you should pay attention to whether it's alleviated when the patient is lying down. Usually that headache is not always bilateral, and that makes it more difficult to diagnose as well. As for some other reasons, maybe we should just think of that, like acute carbon monoxide poisoning, hypothyroidism, again, throbbing headache. And then there is something like, maybe you can think of your patients that if they have a postprandial hypoglycemia, they will be predisposing to migraine. So go and check the blood sugar levels and maybe the HbA1c as well. Many medications can and will cause migrainous headache as well. So you may be thinking in many different other kind of conditions that are comorbidly active among our patients. Some other potential causes of migraines are glaucomas, inflammatory disorders such as SLE, medication overuse headache, that has actually been the third most frequent headache worldwide. And of course, we have the alcohol withdrawal headache and caffeine withdrawal headache that are not that dangerous for our people. Have you ever heard of the SMART syndrome? So it's a stroke-like migraine attack after radiation therapy. And who does it affect? Usually young people aged from 1 to 35. So far, there have been about 40 cases reported of those migraine-like headaches. And what's good about it is that it's a post-radiation reaction of the brain, lasting for about 3 months and afterwards completely resolving. How can you detect it? Well, you should do an MRI, and then you will see a thick unilateral gyrform cortex enhancement that should be involving typically in, shall we say, half a month to 1 month time. We don't know the pathophysiology of it, but we label it as a SMART syndrome. Also, very rare cause of migraine aura, where patients experience distortion in body images, so it's a little bit of a complex aura that we can see here, is the Alice in Wonderland syndrome. In about a little over 10% of cases, a migraine can be causing it. And most of the time, we're going to be thinking of an infection with an EBV virus. So what's important also to mention is that sometimes administering topiramate, which is something that we use for migraine prevention, can also cause this distortion in body language. However, it's completely benign and it will resolve itself by itself. I have browsed a literature a bit just to see if there's anything rare. So I found cerebral neurocystic which is the image that you can see on your right screen side, then neurobrucellosis, then optic neuritis, and then sickle cell disease. So it seems to me that many causes can really mimic a migraine disorder. What about pregnancy? Well, we do know that migraine occurrence during the first and second semester of pregnancy is usually how it is before the pregnancy itself. But in the third trimester, the pregnant women should be headache-free. However, if the headache occurs in the third trimester, you should be really, really aware. Usually it's due to homeostatic disturbances, vascular problems, or some newly occurring space-occupying lesions. So what you should think of is the red flags in pregnant women. And the acronym for it is pregnant HA, which means proteinuria, rapidly onsetting, elevated blood pressure or temperature, gestational age, yes, we said that, third trimester, present and concomitant neurological signs and symptoms, altered level of consciousness, no headache history or prior history of a secondary headache disorder, thrombocytopenia or thrombocytosis, high liver function tests or CRP, and agonizing severe pain. And the last one of our borderland syndromes is migralepsy. Migralepsy is an epilepsy that has been started during or within 1 hour of a migraine attack in a person who has migraine with aura. It's very difficult to diagnose, and it's been started by this case report of 19 patients, and it was published by Lennox and Lennox. And afterwards, this first publication has received some criticism because there was not a meaningful and unequivocal migraine epilepsy sequence. And some of those patients, namely 2/3, seem to have rather symptomatic and idiopathic occipital epilepsy with visual hallucinations. So no migraines at all. But there is a special connection between epilepsy and migraine. We do know that focal seizures can mimic migraine aura. We do know that migraine aura, especially visual one, can be confused with occipital seizures. We have seen the pictures of how auras and seizures look like in the beginning of this lecture. We know that occipital seizures are often followed by a migraine-like headache. So post-ictal headache usually occurs in about 50% of people. But we can also have something called hemicrania epileptica, which is an ipsilateral headache with migrainous features as an ictal manifestation of the epilepsy itself. It is labeled in the ICHD classification as migraine aura triggered seizure. You can find it there if you need it. So now that we know everything that can happen, we should just remind ourselves of the concept of red, orange, and green flags. When should we consider a migraine mimic? Initially, upon initial evaluation, when your patient has first showed up in your office saying, I have a headache. Then you should be thinking of excluding primary headaches disorders first and then secondary headaches. When your treatment response in your patient is not as expected or getting worse, and when your patient tells you that there is more than one type of headache that's present. Why is it important? Well, because primary headaches actually do not pose too much of a danger, except from a stroke risk in migraine. But the secondary headaches can have, if unrecognized, a mortality as high as 50%. Once again, let's summarize this. So primary headache mimics are only several types. So it was easy to name them here. But secondary headache mimics, any condition and all conditions can actually produce migraine-like headaches. So when should you think of that? Well, after taking history and physical examination, because you're aware of the red flags concept, you should be thinking, are there any present? If so, then you should be thinking of secondary headache. And also, after seeing the primary headache disorder diary, perhaps see that there are any atypical features present. If so, again, think of the secondary headache. If not so, just follow this algorithm and choose one of the right diagnoses for primary headaches. What's really, really important is that you do not forget that the last criteria in the ICHD diagnosis is There is no better explanation for the symptoms that you see in your patients. So if there is no better explanation for a migraine, then it is a migraine. The best list to find, red flag list, actually consists, despite the fact that it's called Snoop 10 list, consists of 15 items. It was published in 2019, and it's very extensive. And it talks about systemic symptoms, neoplasms, neurological deficits, older age, pattern changes, positional headaches, precipitation by coughing and sneezing or exercise, the presence of papilledema, the presence of progressive headache and atypical presentations, pregnancy that we spoke of, painful eye with autonomic features, post-traumatic onset of headache, pathology of the immune system, specifically HIV, painkiller overuse, or any new drug at onset of a headache. So those are red flags. So what are orange flags? Orange flags cannot exist by themselves. They can, but they do not raise such a strong awareness. You need to have at least 2 orange flags or concomitantly have an orange flag and a red flag to make it more important. Recently in 2023, a group of authors decided to publish an article and propose a Snoop 12 list, adding 2 more headaches to the original list. The first one will be consisting of post-COVID headaches, which are persistent and maladaptive and presenting as maladaptive neuroinflammation of CNS. And the second one, which makes sense because it could be the initial presentation and then you can think of COVID. But the second one, post-vaccination headaches with a late onset within a week to exposure of the possibility of CVSD, is what makes it really important. So increased coagulability and then secondary occurrence of cerebrovascular thrombosis. Finally, we have green flags. Why are they important? Well, because they actually are safe. So out of all the proposed items on the list, after really taking and evaluating carefully, scientifically, only 5 were selected to be the green flags. If your patient has items from that list, if your patient have items from this list, then you should be thinking of primary headaches. So what are those 5 items? The current headache has already been present during childhood. The patient has headache-free days. The headache occurs in temporal relationship with the menstrual cycle. There are close family members with the same headache phenotype, and the headaches occurred or stopped more than a week ago. So lastly, migraine is both a diagnosis of inclusion and exclusion. So let's graduate now. I'm going to be presenting to you this patient she is 42-year-old woman. She probably had no headaches, and her initial symptom happened on August 6th of last year. She had speech impairment, she was paralytic, and she had pain in her left arm and had centrally affected her left facial nerve. She was hospitalized, but her neurologic deficits subsided about an hour from the start. However, a few hours from the beginning of neurological symptoms, she has developed a new headache, not known to her before. She had no other associated symptoms or signs. And it resolved. The headache not, but the neurological deficit was resolved. So what do we know about her? So from her previous history, we know that she has glaucoma, that she has divergent strabism, that she has been treated for seronegative spondylopathy, that she has had operation on her lumbar spine on several occasions, and because of it, she is suffering from neuropathic pain. Her functions are normal. She is not a smoker. She was a smoker at that point. She drinks 2 coffees daily and 2 liters of water per day, and she regularly exercises. So nobody in her family has headaches. What was she discharged with? Well, she had aspirin, a statin because she had high lipid levels, and then she had prednisone for her spondylopathy, and pregabalin for her neuropathy from before, and sulfasalazine again for her spondylopathy, timolol eye drops for her glaucoma, and for her headache. Recently, she's been starting using a lot of analgesics, namely ibuprofen, paracetamol, and tramadol. While she was in hospital, what were the key findings? So the brain MSCT and the CTA of head and neck were quite normal, as was the carotid ultrasound. The transcranial Doppler showed slightly elevated mean blood flow values, and her ECG was normal. They also did an MRI a little bit later on her, showing some lesions that were explained as perinatal hypoxic ischemic lesions, and she actually had a little difficult birth because she was born as a twin. They performed an MRA and an MRV, and it was normal. And they performed a cardiac ultrasound showing an aneurysm of the interatrial septum with no apparent left to right communication. She not only did ECG, but Holter ECG, which was normal. We spoke of those lipids. So what did they do then? They did the bubble test that was positive. They tried to find some sort of immunological issue going on, so everything was negative. And they also sent her to perform a neuropsychological examination where she had higher intellectual verbal function, but mildly diminished executive functions. And it was quite impossible to distinguish whether it was really something coming from the brain itself or a psychological version. She was just discharged as a TIA in the end. That's why all of that was happening. She came to see me, it was September 11th. Why? Because ever since then, she has had a daily strong VAS 6 to 8 throbbing headache, not happening. She has changed, her quality of life has dropped so much. Where was it located? So dominantly occipital, bilateral, and in the cervical spine. Were there associated symptoms? Yes, phono and photophobia. She felt alleviation upon resting. One should take note that not lying down, just resting and being still. So she had no nausea and no autonomic symptoms. Her pain duration was obviously lasting more than 15 days per month. And she came to me for consultation. So I asked her I was not sure at this point what the correct diagnosis for her would be. We will talk about this a little bit later. So I asked her to differentiate and to do a cardiac echogram transesophageally to see if there is a left to right shunt finally, because the embolism signals would say that there are. So she didn't come to see me again for at least a month and a half. Why? Because she has had a second clinical event. She kept on having frequent, almost daily headaches. And on a month and a half after her first event, she felt a tingling in her left cheek and left arm with mild motoric deficit. She was again hospitalized. Initially, a CT was performed, and because it was normal, thrombolysis was performed with a complete symptom resolution. But remember, on the first occasion, she also had spontaneous symptom resolution within an hour. However, after this occasion, she had persistent paresis on her left hand, which ended up staying upon the discharge. She had no other associated symptoms or signs. So what did they do? They performed another brain MRI, and they did find the same lesions, but this neuroradiologist, said this time, is it maybe Catacil? But there's no involvement of anterior temporal lobes. Is it maybe demyelination? So they did additional testing. They did visual evoked potentials, which were normal. And they did cervical spine MRI, which only showed protrusions and no other demyelinations. They did the TEE, which means esophageal cardiac ultrasound, showing not only the aneurysm, but a BFO of 1.1 centimeters. The lab findings were inapparent this time. So what has changed? She stopped drinking coffee. She's not a smoker. She has no activities because her headache is so severe. And this time she was given Endoxin because of the BFO. They also suggested that she should check for thrombophilia, which was later found out to be negative. They sent her to do a clinical exon testing. We don't have results yet. And to do a consultation regarding a PFO occlusion. They also proposed to do a control MRI of 3 Tesla in 6 months. So what do you think is the likely diagnosis? What would be migrainous features would be a strong pain, VAS 6 to 8, throbbing pain, photo and photophobia, resting helps, localized pain, neck pain, aura. But what would be secondary features? Vascular events in temporal proximity, PFOs, MRI lesions, no prior headaches, no family history of headaches, residual deficit, NIH1 if you remember at discharge. And is there a better explanation? One can think of new daily persistent headache or reverse cerebrovascular constriction syndrome. We do know that migraine and stroke are interconnected at some point. In this case, this patient had a migraine with aura as a presenting. So there was an overlap. There could be an overlap with our CVS. Did she have stroke? No, we found no signs of it. She might have had a TIA. So we know from Lebedeva study that in stroke units, about 2% of our patients had a migraine aura, in fact, and not a stroke. And 1% of migraine auras were actually, in fact, treated with IV thrombolysis. Was it her case or not? We don't really know. So to clarify between migraines and TIA, one should be aware, and the take-home message here is that slow progression and positive phenomena will distinguish a TIA from an aura or an aura from TIA. Migrainous infarction she didn't have, so we're going to be skipping this one as well. So what is the connection between migraine and PFO? Well, it seems to be a dose response. The bigger it is, the more problems you have. What is the proposition? Well, aspirin. So what were the treatment options for this lady? Acute medication, should we? Well, we don't know because she is not in acute situation. She is at least having a subacute situation. NSAIDs, are they efficacious enough? Should we do the triptans? We don't know. Why? Because they're not good for vascular events. And also, should she take them daily when we know that we could cause an MOH? I don't think so. What should we do about PFO? Well, it's important to think about that, but it's not going to be helping her with the pain. What else can we do? Can we offer her acupuncture? Well, not bad, but it's not going to be helping. Well, what about Botox? Could be efficacious, but maybe a little bit complicated. And what should we do? Well, maybe we could give an occipital nerve block, and that's what we did. And guess what? The patient became headache-free. So without even knowing the correct diagnosis, there is still a big debate among us what actually happened here. She was actually pain-free, and she's quite happy and totally 100% responsive to that treatment. So your main take-home message is that headache history is crucial. When did your headache start? Is there a difference? How many headache types do you have? How often do you get a headache? How long does a headache episode last? Have you recently noticed any change in characteristics? What is the intensity, location, spreading? What associated symptoms did you get? Are there any aggravating and relieving factors? Is there a presence of neurological symptoms? What do you do when you have a headache? And what worries you about your headache? So now I believe you graduated from all this knowledge and you can safely relax, and thank you for your attention.
Thank you, Dr. Yelena, for this interesting presentation and this interesting case. So we're gonna go for some questions from the audience, and I will start by the first one. Which tumor resembles migraine the most? What
That
do
is a very, yeah. Oh, sorry. Did you want to ask something else?
No, I'm asking, what do you think about this question from the audience? Which tumor in general is looking like the most like migraine?
The tumor that looks most like migraine is the one that presents as with throbbing headache. And that's luckily for us, usually a benign tumor called meningioma. The gliomas or glioblastomas usually imitate more a TTH headache, which means that the headache is actually pressing or compressing, something like that. So meningioma is what you should be thinking of.
Perfect. So the second question is how to distinguish between RCVS from migraine.
Yeah, well, RCVS is something that you should think of because there is a good prognosis for that. And also, it does look really disturbing in the beginning, but eventually it is mostly self-resolving. What you should do is you should do an MRI or MRA or a CTA, and then you will typically see a string and bead sign. And this patient did not have such a thing, and she did a CDA. So we can safely say that that RCVS in her condition was excluded.
Perfect. So another question from the audience is what type of headache should you consider in people age 50 and older?
Okay, so most commonly occurring is something like infectious, starting as an infectious disorder. It's most likely a secondary disorder. Let's start from the beginning. And then out of those, it could be either vascular or infectious or space occupying or something dealing with low or high CSF pressure.
Maybe I can add also giant cell arthritis. Sometimes we're seeing mainly.
Yes, I was thinking of that as I was thinking of vascular disorders, yes. Then you should do a blood work as well to find some inflammatory molecules there, such as CR.
Yes. And the next question for you, doctor, is what is the appropriate dose for the endomethacin test? I think he means by endomethacin maybe medication.
Yeah, well, yeah, there is an endo test which can distinguish the hemicrinias from a migraine. Why? Because if you do it the right way and do the proper dosage, then you're quite certain that it's either responsive or non-responsive. We have found out throughout this lecture that migraine can be endomethacin responsive, but not completely. However, the hemicrinias are actually usually 100% responsive. So the correct dosage can be measured in two ways. One is administering IM or intramuscularly by administering at least 100 milligrams, 100 to 200. The other way is that you instruct your patient to do it at home, which means that you will tell your patient to the first week to take 25 milligrams 3 times a day, the second week 50 milligrams 3 times a day, and the last remaining 2 weeks 75 milligrams 3 times a day. After a period of a whole month, you will be certain whether it's responsive or non-responsive.
Perfect. So the next question, it's an interesting question. How do you treat in general new daily persistent headache?
Yeah, that's quite impressive as well because it's usually responsive to some of migrainous medications, and really the most response to Botox treatment. So maybe one, and it's also, we know that the diagnosis can be made after 3 months, so it's a good thing to start with Botox then, because then you're quite certain that it can help.
Dr. Yelena, you have a question from Mr. Surendra. Headache in patients of well-controlled CNS vasculitis. So maybe they mean by if CNS vasculitis is well controlled in general, it makes headache or usually it should improve. Maybe it means by that.
Well,
Not
I would imagine that it should improve if it's well controlled, because there are some inflammatory components causing the headaches. And if you have your inflammation under control, it's probably less aggressive as a headache.
Okay, so the next question is from Muhammad. Where would you place post-dural puncture headache? Any differential that mimics the classical presentation?
Well, yes, postural headache can also imitate a migraine. There is usually bilateral occipital throbbing pain that's quite severe, and the patients are bedridden. If that's the case, there are associated symptoms such as nausea and vomiting, and sometimes they're so severe that you have phono and photophobia, and you really have to treat them sometimes for days on. They can even mimic migrainous status. I have had one of these patients like that, and the headache was lasting really strong one for 7 days, and it was really difficult to treat it. However, we were persistent. we didn't do, nowadays, at that time, we didn't do an evaluation and we didn't do a blood patch. But today I would say first, do a blood patch and then, anything else. What we did is we medicated them. So if you don't have a specialist who is really skillful in blood patches, just, use the regular analgesics along with diazepam and just wait for it to subside. Usually it does.
Mhm. And I'm gonna finish by this question for you, doctor. Can multiple tinea cavernoma cause headache?
Yeah. What kind of cavernoma? Multiple?
As they said, tinea. Maybe he means multiple, or she means multiple cavernoma.
Okay. Well, sure. It depends on the setting where it is. With the brain, it's always where it's situated. So, I was telling you about that if it's happening in the brainstem, then it can imitate a migraine with aura, just having the marching symptoms, evoking the same kind of aura as with the brainstem migraine. So, yes, for sure. And if it's concealed somewhere throughout, like frontal lobes or I don't know, parietal, sometimes it can just become inapparent. So the location is really crucial for this question here.
Dr. Yelena, if you allow me for the last question, do you have any indication for physical therapy before immediate triptans or Botox or other medication, let's say?
I would say that physical therapy is always a good idea. Why? Because the administration of Botox itself means that the headache is originating or being precipitated by increased muscular stiffness. So introducing physical therapy to these patients is really crucial. So what you can do, I wouldn't do it first. I would do it at the same time as well as the medication.
Perfect.
Maybe
Yes.
before Botox, maybe that before Botox, but not other medication. That's what I wanted to say.
Dr. Milenka Yelena Jurasik, thank you so much for this very interesting topic tonight, and thank you so much.
Thank you. You're very welcome. Good night to all.
Thank you. So we're gonna shift our topic to another very interesting topic about how can we better match migraine treatments to our patients' needs. That will be presented by Dr. Ammash, Dr. Zakaria Ammash, senior consultant. He went to medical school in Toulouse, France, did a residency in internal medicine at the AUB, American University of Beirut, did residency in neurology at the University of Iowa Hospital and Clinics, a fellowship in movement disorders at the University of Iowa, was chairman of neurology at Clemenceau Medical Center in Beirut from 2005 till 2020. He's currently senior consultant at SSMC, UAE, and member of the Arab Board of Medical Specialty. Dr. Amash, the floor is yours for your topic.
Good evening, everyone. It's always a pleasure to be part of those migraine master classes. I'm very happy to be here today. In the next 40 to 45 minutes, we'll be talking as usual. Dr. Rodi, do you see well my screen?
Yes, Dr. Amash, it's very well seen. So you can proceed if you want.
So in the next 40 to 45 minutes, we'll be talking about different signs and symptoms of migraine, and we'll be going over recent data. This time, my lecture will be different from previous time because I already presented this lectures in the past. However, we'll be adding some cases. We'll be discussing about those cases and what is the best approach and management of those patients. First, epidemiology of migraine. As you all know, migraine is a complex disease. It's not only a matter of headache. It's a very complex disorder where there are many signs and symptoms associated with the pain by itself. It is estimated that 1 billion people are affected by the disease all over the world. 75% of them are women and 25% are men. Before puberty, the prevalence and incidence of migraine is higher in boys than in girls. However, after the age of 12 and secondary to hormonal changes, it's more frequent in female. This is the result of a study that was published 2 years back in 2016. And this is one of the most favored study. It was a huge study involving around 60 countries with around 360 to 65 centers, where they were looking for the prevalence of the diseases all over the world and the number of years lived with disability secondary to the disease. In 2016, it was estimated that migraine was the second leading cause of year lived with disability worldwide, and it was more prevalent in the high-income country. At that time, migraine was more prevalent than asthma or epilepsy. In our region, the Middle East and North Africa region, migraine was the second leading cause of disability in our society. As I have said a few minutes ago, I mean, migraine is not only a headache. Migraine is a complex disorder. It's a chronic disorder where there are many and multiple signs and symptoms. Usually, it starts with what we call the prodrome phase, where those patients are having multiple non-specific symptoms, such as irritability, depression, food craving, difficulty in concentration. They have a muscle spasm, fatigue. This prodrome will last a few hours to a few days. Then they have what we call aura. Aura is present only in 30% of the cases, and it can be any focal neurological disorder. Any focal deficit can be an aura. The most common being visual disturbances and hemisensory loss. After the aura will come the headache. The headache is a unilateral throbbing pain associated with nausea, vomiting, photophobia, phonophobia. Those patients are in such a bad shape that they are unable to move. You know, one of the characteristics of migraine, of pain secondary in migraine headache, is that the patient will come and tell you, whenever I'm having this migraine attack, I'm unable to move. The pain is exacerbated by physical activity. This is why they go and lie down and try to close the window and try to sleep. The migraine attack by itself usually lasts between 4 to 72 hours, and usually it's followed by the postdrome. The signs and symptoms of postdrome are quite similar to the signs and symptoms of prodrome. It only lasts a little bit longer than the prodrome. It usually lasts between 24 to 48 hours. Migraine has a huge impact on our society. In a questionnaire that was sent a few years back to a patient who one of the member of the family was affected with migraine or having migraine, this study or this questionnaire gave the following result. The majority of them, or good part of them, reported that they have a reduction in their quality of life secondary to the headache, that life would be better without headache. It has a negative impact personal relationship. 64% of couples where one of the members was having headache reported that it's affecting their life. 37 to 40% have some spousal relationship problem. 50% report that they have reduction in their family activity, such as attending parties, taking kids to school, taking kids to different type of activity secondary to the headache. When they look into the professional part, 70% of those patients reported that it's affecting their professional life. 43% of those patients had reported having some disability secondary to the anxiety. You know that patients who are having migraine headache are very often anxious or very often depressed. Why? Because whenever they are having this migraine headache, they are always worried that they might have another migraine headache. So those patients are living constantly in a stage of anxiety or depression, being afraid from having another attack of migraine. And this was also estimated that 52% of those patients were suffering from depressive episode or depressive symptoms secondary to their migraine. This is to show you one more time the big impact of migraine on our society. This is another interesting study. This time, the questionnaire were not sent to the parent or to the patient. They were sent to teenagers living with one parent who is having migraine, either mother or father who are having migraine. And let me share those results with you. Very interesting result. When they were asked how many times during the past 30 days did you need help from your parents and couldn't get it, 27% of those patients reported they were unable to get it in patients with episodic migraine versus 50% in patients with chronic migraine. When they were asked during the past 30 days, how often did you feel angry at your parents from having headache, 14% of the children with episodic migraine were angry at their parent, and 25% with chronic migraine. 22% of those patients report, or the 22% of those adolescents reported that missed family gathering or activity at school secondary to their patient disease. When they were asked if it was affecting or it was interfering with their performance at school, 7% reported of those children reported that it is affecting their performance at school, in patients with parents having episodic migraine, and 15% in patients who are having chronic migraine. In summary, migraine it has a big burden on our disease. It is very important to recognize the disease as soon as possible and to be very aggressive in terms of treatment, just to trying to limit the impact of this disease on our society. How do you approach patients with migraine? Usually, the treatment of migraine is divided into two parts: the acute part and what we call abortive part, and the preventive part, or what we call prophylactic part. Patients usually require both of them. The target of the acute treatment is to reverse or at least to stop the progression of the headache that has started. The target or the aim of the preventive treatment, which is usually given in the absence of headache, is to reduce the frequency and the severity of the migraine attack, to make the acute attack more responsive to abortive treatment, and to improve the quality, the patient's quality of life. Sorry, small, okay. Those are the medication that they are available, that we are having available to treat a patient with an acute migraine attack. I'm not gonna go over them. The majority of them are usually triptans. We have some non-steroidal, we have simple analgesic, we have opioid, and now we are having what we call the CGRP antagonist. Whenever you decide to treat someone, or you took the decision to try to help someone who is having an acute headache, you have to put some target. And the American Headache Society set some goal that whenever you are treating someone with acute migraine headache, those patients should have a rapid and consistent freedom from pain and associated symptoms without any recurrence. And this should be done as soon as possible. So any medicine you are prescribing to those patients should be able to help those patients to restore their ability to function as soon as possible, and to avoid taking another medication or drugs later on. Those patients has to be able to go back to their function. We have to use a medicine where we don't need to take another rescue medication later on, and it has minimal side effects. Unfortunately, there are various unmet needs associated with the traditional acute treatment. It is estimated that 43% of patients experience adverse event within 24 hours from taking acute medication. It is estimated also that 67 to 80% of patients have recurrence of their pain. Medication overuse headache is very common with the simple analgesic or with triptan that we have been using over the last few years. And luckily, medication overuse headache is not being found in patients taking CGRP antagonist. And number 4, unfortunately, most of the analgesic that we were having so far and what we were using before the era of CGRP antagonists were associated with contraindication. To give you an example, indomethacin or any anti-inflammatory that's usually contraindicated in patient who is hypertension or with kidney disease. Also, non-steroidal are contraindicated in patient having a GI ulcer. Triptan are also contraindicated in patients who are having hypertension or are having any cardiac issue. What about the preventive treatment? When shall we consider using preventive medication? What we used to do in the past, and to teach resident and the student, that we have to consider preventive treatment whenever we are having patient who are having 2 attacks or more per month, which is in a kind of true. However, what about if we are having a patient who are having only 1 attack per month? However, this attack is so bad that he or she gets sick for 24 to 48 hours, and they are unable to function for more than a few days. Would you not give them preventive treatment? In fact, let me tell you my personal experience. I usually try to give preventive treatment if really those patients are having 2 attacks or more per month. However, if I know that my patient is having 1 attack per month, and this attack is so bad that's going to put them in bed for 1 week, I go ahead and give them preventive treatment. We should also consider preventive treatment in patients who are having contraindication or who fail acute treatment, patients who are having tendency to overuse analgesic, and patients who could not tolerate acute treatment. Those are the different medication that we are having and that can be used as a preventive treatment. We have the calcium channel blocker, that it has very limited efficacy, honestly. We have beta blocker and tricyclic antidepressant that has been used for many years. However, unfortunately, they have been associated with many side effects. Anti-epileptic drugs such as valproic acid and gabapentin. We have botulinum toxin, and we have the new CGRP antagonist. We were facing in the past, and this is one more time before the era of the CGRP antagonist, some problems that were associated with preventive treatment. One of them is the delay in efficacy. The first thing that I usually used to say to my patient, I'm going to give you a treatment for migraine. However, this treatment for migraine, it's going to take 4 to 6 weeks to kick in. So you have to be patient, and meanwhile, you have to stay on analgesic. This is true. It is estimated that sometimes it can take 4 to 6 weeks before the old preventive treatment, such as beta blockers or antidepressant or topiramate or depakine, to kick in, which is completely different with the new CGRP antagonist. Also, as I have mentioned a few minutes ago, those medicines are associated with a lot of side effects. Tricyclic antidepressant associated with weight gain, sexual disturbances. Depakine is also associated with weight gain, hair loss. Fatigue, which is associated with tricyclic antidepressant. Depression associated with topiramate. Cognitive functioning or cognitive dysfunction also is associated with topiramate and tricyclic antidepressant. Beside all those side effects, there was a very interesting study that was published a few years back where it showed the number of medication that are being used by the patient to control their headache. This was a cross-sectional observational study, evaluated medication taken by 300 patients with primary headache to assess rate of polypharmacy. It was estimated that 4 medication or 3.8 medication with the average number of headaches medication used by the patient. And it was also estimated that more than 5 medications of daily numbers of medication were taken by 41% of those patients. And those were all combination of preventive and abortive treatment. Now things change dramatically. I mean, since the beginning of the era with CGRP antagonist, things are definitely easier, where there are now pills that can be working as an abortive treatment and preventive treatment, such as rimagepran or Nurtec, and we'll be talking about it a few minutes later. In fact, CGRP peptide, calcitonin gene-related peptide receptors, or the amino acid neuropeptide as being a major contributing factor in the pathophysiology of migraine, the concept is not new. This has been present for more than 2 decades. And this has been noticed by the researcher more than 20 years ago, where they noticed that there was increase in the blood and salivary level of CGRP in patients with migraine attack and between migraine attack in patients with chronic migraine, cluster headache, neuralgia, chronic paroxysmal hemicrania, and even rhinosinusitis. They even noticed that whenever we are giving an infusion of CGRP, that there were triggering migraine attack. From this, we're born the idea, what about if we try to create new molecules, which are the CGRP receptor antagonist? Could it be helpful in treating migraine attack or treating pain in general? And it turned out to be true. In fact, CGRP has also not only benefit in migraine and pain in general, but there have been some studies showing that CGRP can have some cardioprotective action. However, unfortunately, there is not enough data to talk about it. Also, I would like you to know that there are also some minimal data mentioning that CGRP can be helpful in patients with neurodegenerative disorder. However, also, this is I would take it very cautiously, since we need more data and we need more study to confirm what I just have said. Those are the different type of CGRP inhibitor available. We have the monoclonal antibody, and we have the Gepan, rimagepran, and ibrogepant as a CGRP receptor antagonist, and the monoclonal antibody are irinumab, eptezanumab, calcanezumab, and fremanezumab. Fremanezumab is not available in the UAE, not yet at least. So whenever we decide to try to treat, we decide to try to treat a patient with migraine, we have to have two targets, or we have to have two ideas in our mind. First, people do not like to take medicine. So the less you give them medicine, better will be the compliance with the medication. The more you give them medicine, they will have tendency to use or to take the medicine less and less. On the other side, it is very important to try to negotiate with the patient or to talk to the patient, to explain to the patient that now things change completely. Now we don't use the old medication, that we have an alternative of those medicine. Try to tell about the patient about the CGRP antagonist in general, about the benefit and the side effect. Now, what I will be doing, I will be showing you some data regarding Rimagepant or Nurtec that has been showed to be efficient in the treatment of acute migraine headache. However, instead of showing you only the data, what I will be doing, I will be sharing some cases with you. And at the end of each case, we'll be talking about those data. First case that I would like to present is Sarah. Sarah is a 39-year-old female patient who has 3 children, and she worked primarily as a school teacher. She presented with 3 to 5 headache days per month and has been having migraine since she was 19 years old. Her migraine is associated with aura, and it's associated with nausea, vomiting, photophobia, and phonophobia. Sarah, unfortunately, also is diabetic. She tried many medication and many analgesic in the past, such as paracetamol and ibuprofen, with no benefit. She is currently taking insulin for her diabetes. She used to take sumatriptan and tolmatriptan in the past, but she had to stop it because of the chest pain. What are the alternatives and what can we offer to Sarah? Rimagepant or Nurtec is an option. And let me show you now the data that have been showed the efficacy of this medication in an acute setting, whenever you are giving this medication to abort a migraine attack. Just keep in mind that Sarah is having usually 2 to 3 attacks per month. So you can avoid giving her prophylactic medicine and just give her, abortive treatment. This is the study, the first study that I'm going to show you. This is what we call the 303 study. This is the study behind the FDA approval of Nurtec in the United States. It was a multi-site study, double-blind placebo-controlled study. The eligibility criteria were patients were 18 years old and above. They have more than 1 year history of migraine with or without aura. They have the onset before the age of 50. They were having more than 2 attacks or less than 8 attacks per month. It's moderate to severe in intensity. And those patients were divided into 2 categories. One category received 75 milligrams of Nurtec, and the second one, a placebo. They were given a diary, and they were asked to keep the diary updated about the current pain and symptoms, if they had any photophobia, phonophobia, or nausea. The primary endpoint in the study was the freedom from pain at 2 hours post-dose and the freedom from the most bothering symptoms. Just to remind you that the most bothering symptoms are nausea, vomiting, photophobia, and phonophobia. The secondary endpoint, and there was 21 secondary endpoints, reflect the relief at 2 hours post-dose, early action, 60 to 90 minutes, durability of the response, and if they had to use any medication. And finally, they were checking for safety and tolerability. As you can see, there is a significant difference in terms of response to Nurtec versus placebo in patients who are having acute migraine attack, where there was 142 patients versus 74 patients who were pain-free within 2 hours. There were also significant difference in terms of being free from the most bothering symptoms, 235 versus 183. In terms of secondary endpoint, pain relief were present at almost 400 patients versus 295 in patients with placebo. What is very interesting is the fact that 86% of patients did not take a rescue medication within 24 hours post-dose, which means that those medicine not only can kick in within a few minutes, but the benefit can last up to 24 or 48 hours or even longer. Also, when we looked at the primary endpoint, we see that there is a significant difference between Rimagepant and placebo in terms of being free from pain and in terms of being free from the most bothering symptoms 2 hours after taking the dose. In fact, what was very interesting is the fact that Rimagepant was significantly superior to placebo in 19 of the 21 secondary efficacy endpoints. Those secondary endpoints were divided into three categories: early action, 2 hours effect, and durable effect. Please ignore this, what you have on the right side. I'm going to show it to you more in detail. Those are the endpoints. Don't worry, I'm not going to go into details. I just need to show you few of them. The first one is that there was a pain relief in patient taking rimagepant. Okay, I think, are we okay?
Dr. Zakaria, I think we are still able to listen to you.
Can you hear me? Can you still hear me?
Yes,
Yeah.
yes, doctor. Yes.
No
Okay.
problem.
Very good. So I was talking about those secondary endpoint, and as you can see that there is a significant difference between in terms of pain relief between the patient taking rimagepant versus patient taking placebo. I'm sorry. There is also, oh, I need to. There was also, I have a small problem here. Okay, here we go. Now it's working. So there was significant difference between, in terms of pain relief, between patient taking rimagepant versus patient taking placebo. And not only within 60 minutes, but even 90 minutes later, those patients were still benefiting from the medicine. If we look at the durable effect, which is considered between 24 to 48 hours, there was 47% of those patients were still having good time with no pain, compared to 27% of patients with placebo. This show one more time that those medicine are efficient not only in the acute treatment or within a few minutes, but even they have a very long duration of action. What about the response to triptan? There was a very interesting question that was asked during the study. Is there any difference in terms of response to CGRP antagonist if the patient had previous experience with triptans? Which means if the patient had success with the triptans in the past, does it mean that he's going to have success responding to the CGRP antagonist? Or the opposite, if he failed the triptan in the past, if he's going to fail CGRP antagonist? And in fact, they divided the patient into 4 categories: triptan naive, where they were not taking any triptans or never took triptans; patients who were taking currently triptans at the same time that they were enrolled in the study; patient who had history of failure with 1 triptans; and patient who had history of failure with more than 2 triptans. And it turned out that regardless of the patient response or previous response to triptan, the patient will respond to CGRP antagonist. So getting any benefit from Migraine or not using Migraine or any failure to Migraine in the past, to triptan in the past, does not mean that those patients will respond to CGRP antagonist or will fail CGRP antagonist. So regardless of their previous experience with analgesic or any type of analgesic, you have to go ahead and try to see if it's going to work or not. So in this case, the first case of Sarah, this patient needs rapid symptoms relief to the busy nature of her job and lifestyle. Previously, she took many rescue medication to help her headache, and unfortunately, she cannot take any more because of the side effect. In fact, this is a typical case where this patient can be given 1 tablet of rimagepant or Nurtec when needed. The maximum dose is being 75 milligrams, and this what was done. And in fact, the follow-up after a few months showed that there was significant improvement in terms of this patient quality of life, where now she is having 1 to 2 headaches per month. She's taking less medicine and she's taking less sick days. The second case is the case of Fatima. Fatima is a 25-year-old female patient. She's an academic. She is currently conducting research for her PhD. She is presenting with frequent migraine headache. Their headache is similar to the first patient, to Sarah headache. It's unilateral atopic in nature, associated with nausea, vomiting. However, she does not have aura, and the frequency of headache is more. It's estimated to be between 6 to 8. This patient, besides having her migraine, is also asthmatic. Medication history, salbutamol for asthma, sumatriptan with a very inconsistent result. This patient, as you all know, cannot take beta blocker due to her asthma. And she tried amitriptyline in the past, but she couldn't tolerate it because of the side effect. So this is a patient with chronic migraine who's having 6 to 8 attacks migraine. What is the role and what are the results of the study done about the efficacy of rimagepant as a preventive treatment? This is a study that was published in 2021 in the Lancet Neurology, where those patients were divided into two categories. Around 350 patients received rimagepant and 350 received placebo. And in fact, they were looking, the primary endpoint was the reduction in the monthly migraine day. And as you can see that there is a significant difference between the patient taking rimagepant versus the patient taking placebo. And it was estimated that 50% of those patients had more than 50% reduction in means number of moderate or severe migraine monthly day during the, weeks 9 and 12, compared to 41% in the placebo group. Another study, this is also the study 305. This was a two-phase study. The first one was a double-blind trial, 1 to 3 months, and the second one was an open-label extension. This showed that there was efficacy not only first 3 months, but that there is sustainability in terms of efficacy of this medicine, where those patients were still having benefit from taking rimagepant 16 months after the beginning, and there was significant reduction in monthly migraine day by 7 days. Another interesting study, this one was what we call challenge MIG trial. You know that there is no study or there is no head-to-head trial to compare monoclonal antibody against Japan. There is a meta-analysis that was published in New England Journal of Medicine a few months back, comparing all CGRP antagonists. This is the first one which were head-to-head trial. And in fact, those patients were 18 to 75 years old. They were having more than 1 year history of migraine, with or without aura, and they were having a positive migraine, 4 to 14 headaches per month. They were divided into two categories. The first one received calcanezumab 120 milligrams sub-Q monthly, and the second one received rimagepant. And the primary endpoint was to see that calcanezumab was superior to rimagepant in reduction of more than at least 50% of the monthly migraine headache. Unfortunately, or fortunately for whoever you are looking for, which drug company you are talking about, which drug company you are talking from. In fact, calcanezumab failed to meet the primary endpoint. And it showed that there was no statistical significance between calcanezumab and rimagepant. So it showed that despite the fact that we had this idea in the past that calcanezumab is a potent CGRP antagonist, that it's not better than rimagepant. And since they failed to meet the primary endpoint, the secondary endpoint also was not considered to be statistically significant. When we looked at the serious adverse event comparing calcanezumab to rimagepant, there was nothing really serious or not a big difference between both of them. The nausea, fatigue, injection site pain were quite similar in both groups. There was only one case of pulmonary embolism that was reported with the rimagepant. However, it turned out that this is not related and that the participant did not declare it before the study. So it was concluded that this is non-clinical meaningful difference. This is not clinically significant. When we look at those medication in general, we can notice that those patient tolerability and benefit are quite similar. And this is what I was telling you a few minutes ago, that was published recently in the New England Journal of Medicine, that in fact, when we compare rimagepant to erenumab, to calcanezumab, to framezumab, I mean, the benefit is quite similar. And the side effect is quite similar. The advantage of Nurtec is the fact that it's a pill, and patients do not like injection sometimes. That it's very favorable and very little side effect. But what is also very important is that the half-life is very short. It is estimated to be 11 hours compared to a few weeks for the CGRP antagonist. And this is a very important problem in patients who are childbearing women. Regarding the case study number 2, so this patient, we need to treat her, Fatima. However, we have to take into consideration that she needs a treatment that will not disrupt her quality of life, will not have any side effect, and will have a good benefit. In fact, this patient was started on Rimagepant, 75 milligram, 1 tablet every other day, and she did very well. She was seen a few months later, and she reported significant improvement on the medication. The third case study, and it's going to be the last one, this is different. This is Noha. Noha is a 23-year-old female patient, lawyer, newly married, and thinking about starting a family in the near future. She has been having headache for the last few years, since she was 13 years old, and they occur 3 times the first year, and an intensity 5 out of 10. They are bilateral, steady or throbbing. She has to come from school or to stop playing with her friend whenever she had her migraine attack. At 18 in high school, her headaches become more frequent and severe. They occur once per week and lasted from 5 a.m. till she went to sleep that night. The intensity was estimated to be 8 out of 10. It's a throbbing associated with photophobia and nausea. During those attacks, this patient was unable to think clearly or to do her homework. At that time, when she was younger, she was started on propranolol 60 milligram. However, unfortunately, it prevented her from exercising daily to the shortness of breath, and it was associated with some depression. Noted that beta blocker can be sometimes associated with depression. She took many analgesics over the last 12 years, few years, including triptans, anti-inflammatory, and other. At the age of 23, she was working as a lawyer in a stressful job, and she was having 1 to 2 times migraine per week. With the stress and with age and starting a new family, unfortunately, she started having more and more migraine attack. And it is estimated now that she is having between 8 to 9 migraine days per month. She is newly married, and she is thinking about starting a family in the near future. And this is a scenario that you're going to be encountering more and more. In fact, it's very simple. The half-life, without going into detail and complicating things, the half-life of the anti-CGRP is estimated between 27 days and 31 days. The half-life of Nurtec is 11 hours. Usually, it's 5 half days after stopping the medicine. The patient should be clear or should be safe to undergo pregnancy or to go ahead with the pregnancy. So which means that in patient taking Nurtec, she can get pregnant within days, 1 or 2 weeks maximum. However, patient taking anti-CGRP will need to wait at least 5 to 6 months before considering any pregnancy. This is one issue. The second issue, I just want you to know that the side effects and the adverse event that has been reported with all CGRP antagonists are quite similar, and they are very minimal when we compare them to triptans or to non-steroidal. So what shall we tell this patient? What shall we give the patient? We have to give the patient this patient a preventive treatment that will lower her migraine frequency, that have a very short half-life, and it is something which is flexible to her lifestyle and changing her migraine needs. Here we can give her Rimagepant, 75 milligram, 1 tablet every other day. The patient, in fact, was started on this medicine and did very well. In conclusion, Rimagepant or Nurtec is the only medicine that is available currently where we can hit 2 birds with 1 stone. It can be used as an acute treatment, 1 tablet when needed. It can be also used as a preventive treatment, 1 tablet every other day. It showed its efficacy in terms of the acute treatment and in terms of prevention. It has very little side effect. It's a very safe medicine, very easy to prescribe. And the most important that this medicine, whenever it's very safe to be given to any childbearing woman. Those are the recommendation that's being written in the pamphlet. Thank you.
Thank you, Dr. Amash. Dr. Zakaria Amash, thank you so much for this interesting topic and those data, the new data about especially NeuroTech. And I would like also to say thank you again for Pfizer for sponsoring us for this 13 migraine master class. Thank you even for IVPN and also to the Association of Migraine Disorders. Dr. Zakaria, I have a few questions from the audience. The first question is, what's the role of electromagnetic therapy? I think what they mean, those like material like cephaly or those material that sometimes patients are using for their migraine. So what's your advice for those machines?
This is alternative therapy. I'm not against it. I believe that we can try it. There is no data mentioning if it really works or not. There is not enough study to give us a true opinion about the benefit of this medicine, of this method, if you want, of this treatment. You can try it. I'm not sure it's gonna work, but it's worth a shot if you wanna try it.
Perfect. So, Dr. Amash, the second question from the audience about pneumolar headache and underdiagnosis, but common and misdiagnosis as depression, anxiety. Psychiatrist needs to refer such. Okay, so let's make summary for this question. Can you review for us a little bit the pneumolar headache and how do you differentiate it from other like primary headache?
Pneumolar headache?
Yeah, pneumolar headache is especially when the patient is describing those localized pain. Sometimes when they come and describing like some area that is painful. So in general, how do you treat those kind of localized pain?
If first of all, we have to know where is the pain exactly. If the pain is reproducible by palpation, if there is anything underlying, if there is any, I have seen patients coming to see me with a headache. I have a pain here, and it turned out to be a skin infection or something very minimal. I'm sure, Dr. Rodi, that you have had similar patient in the past. In fact,
Yes.
when the patient is having very localized pain, and this pain is reproducible by palpation, or it's a pressure-like pain, and they don't have any red flags, I usually give them a course of anti-inflammatory. Whenever they are having any red flags, and just to remind you, I think that Dr. Jurasik mentioned about the red flags in the previous lecture. Whenever those patients are having any kind of red flags, or there is anything suspicious, we have to go ahead and send them to do an imaging of the brain.
Thank you so much for your answer. Dr. Amash, Abdullah is asking you, are CGRP antagonists also effective in treating acute migraine attacks along with comorbidities like depression?
Yeah, definitely. That's a very good question. Yeah. There is no contradiction between depression and the CGRP antagonist. They are very safe medicine, by the way.
And can I add something? By the way, Dr. Zakaria, did you remark sometimes when we treat correctly the patient for migraine, many times I have patients coming back reporting for me that really their life changed. Even sometimes I'm seeing that psychologically the patient is better. Did you have experience about that?
Yeah, of course, I agree. Migraine is so bad that those patients can get depressed, and whenever you are controlling their migraine, the whole life will change.
And sometimes even they don't understand that it's part of the migraine, and this changing of social life, family life, everything due to this headache. I have too much patients really reporting the same in my clinic. So, and it's very interesting, especially with the new medication like Nurtec, that really we see the difference. So, Dr. Amash Carlo is asking, what abortive medication do you recommend for patients taking Nurtec on the days they take it?
Yeah, this is also very good question. Usually, this is what we should be doing. Usually, we prescribe Nurtec 1 tablet every other day. Okay. In fact, unfortunately, some of the patient will still have some breakthrough pain, so they can have attack, but instead of having 5 or 6 attacks per month, they can have 1 attack. In this case, they can have an extra tablet of Primazepam. So what I usually do, I give my patient 1 tablet every other day, and I give them another box of 8 tablets and tell them whenever you are having pain, despite taking the prophylactic, you can take 1 extra tablet of Primazepam, and it will abort the pain.
Thank you for this. Dr. Ammash, one of our audience is asking, I think the same question as physiotherapy, or patient as well, sorry, patient as well control with sumatriptan and planning to get pregnant. In this case, should patient change her medication to Gepant?
Oh, no, she should, I mean, if she's planning to get pregnant, she should not be taking any medicine. Let's make it clear. She has to stop the medicine, and she has to be off medicine. She can barely take paracetamol during pregnancy. Japan, I mean, Nurtec or Japan in general are safe because the patient 1 week to 2 weeks after stopping the medicine, she can get pregnant. But it doesn't mean that she can still take it during the pregnancy. No, she has to stop it before getting pregnant.
Excellent. Doctor, I think the next question was also answered from your side about pregnancy. The last question for tonight, in your opinion, is do you use prednisolone for treating as a treatment for migraine?
In status migraines, I did in the past. In status migraines, I did in the past. I don't do it on a regular basis. I have honestly very little experience with it. I have used it maybe 4 to 5 times only, last 22 years of practicing neurology. And I use it very rarely, and it can help in status migraines, but I don't use it in regular migraine.
Thank you so much. So I think one of the audience, okay, خلاص, it's fine because I think he deleted. So Dr. Ammash, thank you so much for tonight for this very interesting topic. Thank you again for all the sponsors for tonight. Thank you for Migraine Masterclass. And finally, I'm gonna keep the floor for Dr. Maya to keep you updated for the next session, inshallah. Thank you so much.
Thank you for inviting me. Thank you very much.
Thank you so much.
You are always the most welcome, Dr. Zakaria. So let me start by thanking our excellent speaker and moderator. So thank you, Dr. Rodi Nawar, for always accepting our invitation and for moderating perfectly our migraine master classes. Thank you, Dr. Zakaria, for sharing your expertise with us and for those very interesting clinical and real-world evidence about the safety and efficacy of Primazepam. We really need real-world efficacy beside the clinical trial data about the efficacy of the medication. So thank you for sharing those cases from your clinic and for being with us despite your busy schedule. Also, thank you, Dr. Milanjenka, for accepting our invitation. And the big thank you goes for our attendees, our numerous attendees for tonight who stayed with us until the end of this webinar. Also, thank you for our sponsor, Pfizer, for supporting us in improving knowledge about migraine disease so we can try to optimize the care of our migraine patient in our region. Also, thank you for our collaborator, the Association of Migraine Disorder. Without their effort and input, we couldn't have done these excellent and high caliber activities. So thank you, everybody. For our attendees, you will receive your certificate of attendance by email within 1 week of today. And if you, I saw a lot of questions from you asking to have the recording or you want to revisit the lecture. So here is the good news. All our event will be posted on our IVPN library, and you will have access to all the presentations within 1 week from today. So feel free to visit our IVPN library website where you can revisit all the lectures. And don't forget to always follow up on our social media platform to stay tuned about our next educational activities. Until I meet you again, stay safe, everybody, and have a good night.
Night.
Good night.
Thank you.